Thank you, sir, for kind words of introduction. Let me thank Dr. Vijay Kumar and organizers of 3DCon for allowing me to speak on this topic. I know that this is somewhat like taking calls to Newcastle to explain this simple topic to this august audience, but I'll try my best. So, we all know that steroids are very commonly used drugs, and they have been used and misused widely, especially in the context of COVID pandemic. We have had lots of misuse of steroids and all the adverse effects inherent therein. But what's to be remembered is that all glucocorticoids can cause glucose intolerance, and it is basically dose dependent. And what is the ceiling dose beyond which you get glucose intolerance? It is 7.5 milligram per day of prednisolone or its equivalent. I'll show you the equivalent dose of various steroids in a moment. And now we have to discuss this under two headings. One is steroid use in somebody who is not known to have diabetes, in whom a deterioration in glucose tolerance can happen, and people with diabetes in whom the glycemic control can deteriorate. So we will discuss this under two heads. And when you give a steroid to somebody with diabetes, the deterioration of glycemic control that occurs is rapid. In fact, if you give an IV steroid, it can start happening within 2 to 4 hours. When you give an oral steroid, depending on the time action profile, it can vary from anywhere between 6 to 24 hours. But in those without diabetes, when or whether they will get hyperglycemia depends on a multitude of factors, such as the family history, the beta cell reserve, the level of obesity, and so many other risk factors. There are some people who never develop hypoglycemia on steroids also, although that is quite rare. And in most of these people, when you stop the steroid, the hyperglycemia resolves. Unless it has been, it is a latent diabetes which has been unmasked. In olden days, people used to have the steroid stress GTT, something similar to that. And what type of steroid can cause hyperglycemia? It is basically the systemic steroid. That is the oral preparation and the IV preparation. It's very rare with inhaled preparations, very rare even with intra-articular injection. We have people with periarthritis shoulder who come to us and say the orthopedician has asked for steroid, what will happen to my sugar? Usually nothing happens. Another point to note is that when you use topical steroid, application of steroid cream over a large area of the skin and you cover it with an occlusive dressing, that can actually lead to systemic absorption of the steroid, and especially in children in whom the proportion of the area covered as a percentage of total surface area is high, that can actually lead to deterioration of glycemic control. So these are the relative strengths of glucocorticoids based on their anti-inflammatory potency. Please note that the anti-inflammatory potency is not the same as the diabetogenic effect. This is just a table to show you the relative doses, equivalent doses of the various steroids, taking hydrocortisone as 1. And also remember that difluzacort, for some reason people seem to think that difluzacort is a very benign steroid. Nothing of the sort. It is as bad or as good as any other steroid. So what leads to the hyperglycemia? Use of glucocorticoids. Basically, the main mechanism is impaired insulin sensitivity, and it can occur at the level of both skeletal muscle as well as the adipose tissue, and they mainly augment the gluconeogenesis, not so much the glycogenolysis. And to what extent the plasma glucose rises with steroid use depends on your beta cell reserve. Same mechanism as what happens during pregnancy. Everyone's insulin resistance will increase during pregnancy, but those people in whom the beta cell is capable of overcoming that resistance do not develop gestational diabetes. Just like that, somebody has got a very robust beta cell reserve. Whatever the dose of steroid you give, however long you give, your sugars are not going to increase to any great extent. So how will you monitor and manage a case of steroid-induced hyperglycemia? Now these are all guidelines from the British societies which have been adapted by the RSSDI. Just last year we had the meeting for RSSDI guidelines, and these have been adopted by the RSSDI. So somebody without a diagnosis of diabetes who is being initiated on steroid, you should check A1C ideally. And that's a mistake most of us used to make during the COVID pandemic. When you're starting steroid, we don't think of checking the HbA1c because we have other things to worry about. What is going to happen to the patient due to COVID pneumonia. But in any case, when you start steroid, especially if the patient is older, has a family history of diabetes, obese, such cases you should check the A1C. At least you will be forewarned that you have to do something about it and you have to monitor more frequently. At least once daily you need to monitor the CBG. And ideally you check it pre or post lunch or towards the evening meal, because the normal usual steroids we use such as prednisolone are intermediate acting steroids. The sugars will not go up immediately after the steroid dose. It will only start going up towards the evening. So if you just do a fasting sugar or a fasting and post breakfast, you may miss the increase in glucose levels. And the values are below 200. They're saying 216 because remember this was taken from the British guidelines, so it's all in millimoles. So we can say as a rule of thumb, the values are below 200. Keep monitoring once a day. If it's below 180 consistently, you can probably stop monitoring because that patient is very unlikely to develop hyperglycemia later on. But the values are persistently above 200, at least 2 occasions during 24 hours. We have to increase testing to 4 times a day and probably think of initiating medications. And what are the therapeutic targets? Just as for any other hospitalized inpatients, a target of 140 to 180 is appropriate. Most stringent targets can be utilized if these can be achieved without occurrence of significant hypoglycemia. So what are the therapeutic options? Oral agents may be used in mild cases. Do we have any evidence? Of course, we have some evidence for sulfonylureas, especially glyclazide, and we also have some evidence for metformin. Most of these drugs are considered safe, but efficacy-wise, there is not much of data. See, things like thiazolidinedione, there's no point starting a thiazolidinedione when you're starting somebody on steroid, because this is a slow-acting drug. By the time the drug starts working, the steroid is stopped. Similarly, drugs like GLP-1 receptor agonists, SGLT2, they say you should best avoid, not because it doesn't work, but because these are generally sick patients, especially those who are admitted with COVID and all. We don't want to give them a drug that can cause nausea, vomiting, dehydration. So these are best avoided in acutely ill, only because of the nature of the illness, not because it has anything to do with steroid. But majority of patients will require insulin. If you give enough dose of steroid for enough period of time, they will require insulin. And 2 options are given for initiating insulin, a prandial-based regimen and BMI-based regimen based on the dose of steroid, which is considered to be more physiological and can be more easily titrated. So what insulin to use? You just remember, hydrocortisone is similar to rapid-acting or regular insulin. Prednisolone, methylprednisolone are similar to NPH or Ditamir. And dexamethasone is very similar to Glargine or Degludec. If you remember that, you will know which insulin to start. If you are taking hydrocortisone, you have to give it multiple times a day. You may have to give multiple doses of rapid-acting insulin. If you give prednisolone, methylprednisolone, sugars will go up towards the evening. By next day fasting, it will come down. So give a dose of intermediate-acting insulin or a Ditamir along with the dose of steroid in the morning. That will cover the hyperglycemia. Dexamethasone, probably the hyperglycemia will last for 24 hours or even more. You may require even once daily Glargine or even twice daily Ditamir or NPH. Of course, all only rules of thumb. We'll have to adjust the doses by frequent monitoring. So this is the BMI-based regimen based on the prednisolone dose and the insulin dosage per kilogram. This is only a starting dose. Of course, nobody's sugar is going to be controlled with the starting dose. We'll have somewhere to start somewhere. So this is the starting dose. So in somebody with the previous diagnosis of diabetes, review the glucose control, do an A1C, review the present therapy. Those drugs which need to be stopped have to be stopped. Targets again between 100 to 200. We have to monitor CBG 4 times a day. But if CBG remains stable, which is unlikely, you can reduce the frequency of monitoring to maybe twice a day. Somebody is on parenteral feeds, ICU patient, you have to monitor CBG every 4 to 6 hours. Somebody is on IV insulin, you may have to even monitor half to 2 hours because these people tend to have wide fluctuations of glucose levels. And this is what the British guidelines state about how to adjust the anti-hyperglycemic therapy in people with diabetes who are on steroid. Target again 6 to 10, as I mentioned, around 100 to 200. Increase the monitoring, give education to the patient. If hyperglycemia is there and the patient is on OHA, they are saying glyclazide you can increase up to a maximum of 320 milligram daily with a maximum of 240 milligram in the morning. It's a huge dose. We generally don't give these sorts of doses of glyclazide. Metformin you can increase to a maximum 1 gram BD, which we generally do in our patients. They don't give any option for giving any other non-insulin therapies. If the sugar is not under control with that, you will have to switch over to insulin. Patient is on insulin and still having hyperglycemia, you may have to, first of all, you move the evening dose of insulin to the morning because towards the evening only glucose will go up. If still uncontrolled, you may have to transition to a basal bolus regimen. So points to note are that steroid-induced hyperglycemia can be difficult to control. Oftentimes what we do is we are playing catch-up. Sugar goes up, we try to bring it down, next day again the sugar goes up, but at least you're limiting the damage. The worst thing that can happen is that you and the patient not being aware that they're taking a steroid. That often happens. They go to some doctor, some GP, some quack even, who gives them steroid. They don't know it contains steroid. Sugars go sky high and you see them after 2 or 3 months with all sorts of complications. It is difficult to control not because of the steroid, but many a time because of the severity of the underlying illness. Patient is sick, is in the ICU, having systemic sepsis or something of that sort. Then even if you don't give a steroid, it is difficult to control such patients even with insulin. So large fluctuations can be expected in severely ill patients, those who are post-op, and those who are taking complex immunosuppressant regime like those who are post-renal transplant or post-liver transplant. So in such situations, let perfect not be the enemy of good. Just because you cannot get your glucose levels to 100 fasting, 150 postprandial, do not give up. Let us keep a range of 100 to 200 and try to get the patient within that range as soon as possible. And remember that this too shall pass, because after some time, definitely they will stop the steroid and the patient will get back to normal. That brings us to the last point. Do not forget to step down the anti-diabetic therapy when the steroid dose is tapered. Otherwise, you will have people in severe hypoglycemia. Thank you for your attention.